Good afternoon. Thank you for joining us today. My name's Russ Derry. I'm the Pediatric Epilepsy Program Manager at Mott Children's Hospital. And we're pleased to have with us today Dr. Laurel Reed, who's a pediatric epileptologist with our program. And today's epilepsy expert webinar is on seizure identification and tracking. And I'll let Dr. Reed talk a little bit more about what that means, and you can take it away.
All right, wonderful. Thanks, Russ. Um, so it's a pretty broad topic, and I think what I've tried to do is give a pretty broad overview that might be applicable to many audiences. But as we go through, you'll also see there's a lot of nuances and a lot of things that are very individualized as we sort of think about what might be useful for you and your family or not. And so that may be where some of the questions come in, and we can talk a little bit more specifically at the end as well of, you know, what your unique situation is and whether or not there's something that seems to be a better fit for you in terms of identification and tracking. But we'll kind of do some broad overview stuff first, and then see if there's any more kind of individual things we want to get into. So, a few goals of this talk is one, to sort of talk about, well, what seizures are, what do they look like, what types of events are more or less likely to be seizures. Two, some things of how do you recognize, how do you describe them, how do you track seizures over time, and then three, we have resources and things available for monitoring and tracking, and so I'll describe some of those and give some ideas of things that you might want to try. So, talking about seizures, this is, I think, the part where there is so much, you know, uniqueness about, which type of seizure there is. But very broadly, I tend to break seizures down into two main categories, and that is focal seizures or generalized seizures. And they're going to look different and they're going to have different features. Focal seizures are seizures that start in sort of one specific area in the brain. And so if we think about what are those seizures going to look like, well, the symptoms really depend on where in the brain that seizure starts. And people can be aware of the seizure as it's starting because it's only affecting a very small part of the brain. So if I sort of imagine, right, the brain is this big complex, mapped out organism where each part is interconnected with the others, but each part is sort of responsible for a specific function. Some are more specific than others. So there are some parts of the brain that are really more sort of interconnecting pieces, but there's a lot of spaces that are very specific. So the most simple one is probably motor functions. So there's a kind of strip along the side where all of your movement is really generated from. And so the right side of the brain controls the left side of the body. If I have a seizure that starts in my hand motor area, you're probably going to see twitching of my hand as the seizure starts. And you can imagine that that is true regardless of where you are in the brain. So if it starts in the visual cortex, which tends to be occipital, then I might see something as my seizure starts. If it starts in the parts of my brain that are associated with taste or smell or sound, I might taste something, smell something, hear something as the seizure starts. So, all of those symptoms, depending on what happens at the beginning of the seizure, can help us point to A, it's a focal seizure, because that is how this type of seizure would start, is something with, some sort of more specific symptom most of the time. And it can help point us to where in the brain that seizure might be starting. People with focal seizures often have a warning. You may hear people call it an aura, seizure aura. That's actually the very start of the seizure, is that little bit of sensation of, oh, something's happening. And that is a characteristic of focal seizures, although not everyone with a focal seizure has an aura. And if we want to get into sort of the technical terms, this is something that I don't love, but the ILAE, which is the International League Against Epilepsy, updates their terminology a lot. So our current sort of terms of what we would typically call these seizures are either focal with or without impaired consciousness, and then with or without observable manifestations. So if I was going to give you an example of that same seizure that starts with that, hand jerking, and the person having the seizure loses consciousness during that seizure, I would call that a focal with impaired consciousness with observable manifestations, that hand twitching. Whereas somebody who had a seizure where they just saw something visually and they were able to sort of communicate that whole time, they said, "Hey, I'm seeing it. I'm seeing that blue spot that I always see with my seizures. Oh, and now it's over." Typically, I would call that a focal with without impaired consciousness or with consciousness, focal without impaired consciousness, without any observable manifestations. Because from the outside, I wouldn't have known that that seizure was actually occurring. The person having the seizure had to tell me that it was happening for me to know, hey, this is what you were experiencing. So those are kind of the broad terms, and you can get more specific about like what those observable manifestations are. So twitching, we tend to call, sort of clonic jerking. So you could call it with motor features or with sensory features, but those would be sort of the broad technical terms. So focal seizures, then you can see, could look like tons of different things. And depending on how much of the brain is involved, could be very brief and a very small symptom if it's, only affecting a teeny tiny part of the brain, or it could be something that really causes you to lose consciousness and can progress into a bilateral tonic-clonic seizure. So a full body seizure that started focal and then spread to sort of impact the whole brain. On the flip side, so that's kind of one big category is focal seizures. The other side of the chart is these generalized seizures, and those are seizures that don't start in one particular area. They are sort of routed, so those abnormal electrical signals causing the seizures are routed through the brain and they spread very rapidly. And by the time it gets out to this EEG out on the surface of the head, I see it all over all at once. There's no one particular spot that I can point to. So as you can imagine, instead of that focal seizure where I might have, one tiny symptom, generalized seizures, symptoms usually involve the whole body, so like full body jerking, or full loss of awareness, meaning completely lose consciousness all at once. There's usually no warning or no aura that comes with these because the whole brain is involved so quickly that there's not that sort of build up leading in period to the seizure. And so the terms that might be used for many types of generalized seizures, so there are absence type seizures. These are those seizures that are usually just complete loss of awareness. So some people will call them staring seizures or staring spells, where it's sort of you're you're aware 1 second and then you lose awareness. It's pretty brief and then you come back in. The whole brain is just sort of offline for 3 seconds, 5 seconds, 10 seconds. And that would be a pretty typical absence seizure. A generalized tonic-clonic seizure is that full body, fall down and shake. And so that's the type of seizure that I think if you talk to most people who don't know someone with epilepsy, they would probably say, well, that's what a seizure looks like, right? That's what it looks like when somebody sort of falls down, shakes all over. Would be a generalized tonic-clonic seizure. Tonic, right? You can see that word that's pulled from generalized tonic-clonic. Tonic seizure means you just have body stiffening, but without any of that clonic or jerking type movement. Myoclonic, myo means muscle, clonic means jerk, so it tends to be one quick jerk. This is kind of that exception to, symptoms involving the whole body. A myoclonic seizure, even if it's a generalized myoclonic seizure, you could just have sort of one arm, maybe both arms, something where it's just a really quick, piece of a second, quick jerk. And then an atonic seizure, again, that tonic word coming back. So atonic is loss of tone, and that's what many people would call sort of a drop seizure. So those are the sort of categories of types of seizures that typically fall into that generalized category of seizure types. So there are lots of other, subcategorizations, right, that you could make between these, but this is a pretty basic sort of framework for saying what type of seizure do I have? And then what do I expect it to look like as we go? And typically, if I'm meeting somebody in clinic, we're going to talk about, do I think that the seizure you're describing is focal? Do I think that the seizure you're describing is generalized? And do your EEG and maybe brain imaging findings match up with that? There are a lot of other terms that you might hear. So I mentioned that the ILAE changes their terminology, and sometimes it feels like they do it every 6 months. It's really not that often, but it can be really frustrating because you'll sort of see that the terminology shift. So I'll just point out a few terms. You may hear like a grand mal seizure. That is an older term and is now what we would call a generalized or a bilateral tonic-clonic seizure. So that full body fall down, shake all over, lose consciousness. Um, Petit mal seizure would be sort of the pair to that. For the most part, that maps onto like an absence seizure. So some seizure where you sort of lose awareness, but you don't have, movements or jerking movements. It could match with sort of a focal seizure where you lose awareness and don't have other movements, but typically historically you hear somebody talk about, oh, I had petit mal seizures. Most of the time they're referring to an absence type seizure. And then partial or complex partial are now sort of in the category of what we call focal seizures. And then we sort of label, with or without awareness, like I talked about on the last slide. I do just point out that many families have their own terms to describe a particular seizure type, and there's nothing wrong with that. It's actually very, very helpful because if it helps you sort of keep track of what that seizure looks like, and if that seizure, if something comes up a month later, is that the same as the last one? That works great. So I have some patients who have multiple seizure types and maybe they're all focal. They have two different or three different focal seizure types. And so a lot of families will say, well, this is their right arm stiffening seizure. I'm like, great. I love that because it tells me what happened and what's going on during that seizure. Same thing, oh, this was their blinking seizure. Okay, I think that's their absence type seizure because we've talked about it before. And now we can kind of categorize them all together. So you definitely don't have to use those sort of specific terms, those technical terms like I talked about. You and your neurologist may in clinic sort of parse them down and label, this is the type of seizure that I think that is. But if there's a particular term or name that matches that seizure type, like I love that. I'm always happy to sort of say, hey, you know what that seizure looks like. And now we'll just refer to it by this particular name so that we both know what we're talking about when you describe it or report a seizure to me. So, um, no pressure to sort of learn all the terminology. I think this is the big question that sometimes I'll start asking people a lot of questions about their seizures in clinic, and they'll go, well, why do you need to know? Why does it matter if I know exactly what happened in the seizure? And there's a few different reasons. One is that some seizure types are known to respond to specific medications better than others. So there are some types of seizures, particularly parsing out between focal and generalized seizure types. That's really important for me to know. There are some anti-seizure medications that will make generalized seizures worse if I pick that medicine for you. And so if I don't have a clear sense of what's going on, I may not be able to sort of isolate which medications would be useful. Same thing, there are particular types of particularly generalized seizures where there are some medicines that have been studied and really shown, hey, this medicine works really well for drop seizures. So let's focus in on what's happening. So that's helpful for me. So if I can parse out what type of seizure it is, I might be able to choose a better medicine for you. They're not super specific, meaning there's not like one medicine for focal seizures, but broadly speaking, it can be really helpful. The second thing that I'm always thinking about is that if anti-seizure medicines are not controlling your seizures, then if I know what type or types of seizures are happening, it might help me know if there are other options. So very broadly, like we're not talking about all of these things today, but there are things like dietary therapy. And there's a specific medical ketogenic diet that can help with seizures. There are neuromodulation options, so devices that stimulate either specific parts of the brain or more diffusely that can help control seizures. For some patients, surgeries are an option that can help either control or at times even cure seizures, cure epilepsy. And all of those pieces require a lot more time to think about. But if I know what types of seizures you or your child is having, I may be able to sort of point out, okay, I think we should head down this pathway because of the types of seizures you're describing. And so knowing exactly what types they are and whether they're all the same or some are different is really important. And sometimes we're wrong about what's a seizure and what's not. And we want to make sure that we're treating the right things. So many times, especially if it's a new event that your child has never had before, I want to ask a lot of questions about what happened because my first question is always, is it a seizure? And the second part is, if it's a seizure, what type of seizure is it? But that first question is really important. Is it a seizure? And I will tell you, I have been wrong in both directions. So some things may look like seizures and they aren't. Had kids with really complex or bothersome tics that were seizures, so little motor movements that I thought were myoclonic seizures and they weren't. Non-epileptic events. So some people will call these sort of stress-induced seizures or dissociative seizures. So some sort of psychological stress is causing something to happen that may look very much like a seizure, but anti-seizure medicines are not going to make it better. Dystonia is something pretty common for kids, especially with cerebral palsy, where they may have some limb stiffening at baseline. And if their sort of dystonia medications are a little out of whack or something new happens, they may get sort of tonic stiffening of a limb or multiple limbs. And I may think that's a tonic seizure, but it's actually dystonia. So there's sort of baseline tone problem. Inattention or ADHD, that's a big one. Particularly for either kids with really, really significant ADHD or kids with autism. Very frequently, we are trying to tease out, is this staring spell a seizure, right? They'll say, kid stares off, can't get his attention, can't figure out what's going on. And then 10 seconds later, he sort of snaps back in. And I might say, oh, that sounds like an absence type seizure. And then there are many times when we say, nope, actually, it's not if we capture it on an EEG. So some ways to sort of suss out, is that a seizure or not, is to do a little bit more aggressive stimulation during an event. So sometimes we'll say like, pinch a nail bed, put a finger in their ear, do something that's typically very, very annoying, and something that would typically get their attention to see, are they just zoning out and sort of not paying attention to you because that's what they do? Or is this really electrical activity in their brain that's causing them to be unable to respond? Night terrors are another one. I have been fooled before with a kid who, sat up and had pretty expansive, aggressive movements in the middle of the night. And I thought it could have been a frontal lobe seizure. Those can happen at night. And then we captured it on an EEG and we said, nope, it's actually not a seizure. So lots of things can look like seizures, but maybe aren't. And then on the flip side is some things may not look like what you expect a seizure to be, but could be a type of seizure. Again, if you think about sort of the lay population or people who may not know somebody with epilepsy, they would say, well, a seizure, all seizures look like falling down and shaking all over. And we know that that's not true. These sort of sensory things can be a seizure. One that has come up a couple of times recently that I've identified are kids who have vomiting as part of their seizure type. It's not super common, but it can be. And once we sort of looked at it, we were able to find some other symptomatology, some other things happening around that vomiting that we said, we didn't notice that before, but now having seen it a couple of times, we can tell the difference between, I have vomiting and diarrhea and fever when I have a gastrointestinal illness versus this is seizure related vomiting. So I've been wrong in both directions. I've had families who are really convinced one way or the other, and then we sort of learned the opposite. And so we want to be pretty open and thoughtful about if I'm about to change your anti-seizure medicines or initiate an anti-seizure medicine, that I know what's a seizure and what isn't. Sometimes it's clear, sometimes it's not. So, what do we do when it's not obvious? Because I live in this zone, right? I live in this world with my patients and my families all the time, where sometimes it's really hard to know, is that a seizure or not? My first advice is always take a video. Smartphones have changed our world in terms of how much information we're able to get. People say, a picture's worth 1,000 words. I think a video's worth maybe 1,000,000 words. It's so helpful. One caveat is if your child is having a seizure, I know that taking a video is not the first thing on your list, especially if it's a sort of involved, scary looking seizure. So there's never any judgment, right? If you can't get a video in the moment because you're stressed and you're keeping your child safe, like that is always your priority. But if you're able to, or if there's a bystander or another person home with you, you can focus on keeping your child safe, have somebody else grab a video, can be really, really helpful. Um, they have definitely swayed me one way or the other, where something I thought didn't sound quite like a seizure, and I saw the video and I was like, oh no, that definitely is, and vice versa, where something I thought could have been a seizure, and then I saw the actual event happening and said, actually, I think I was wrong about that. So videos can be very, very useful. Write down what you saw. I have both, a phone and pencil and paper over on the side, images, because it doesn't really matter how you write it down. But a month later, when you see me in clinic, right, even if you called in and described it then, a month later, you may have a harder time remembering exactly what happened. So I always encourage people to write it down. Um, because in the moment, lots of things are happening. That's the other thing that's helpful about videos, right? In the moment, you're stressed, you're anxious, tons of things are happening, and your priority is keeping your kids safe and not necessarily jotting down, the minutia of what happened. If there's a video, then a day later, a few hours later, when everyone is, back to normal, everything's okay, we can go back and look at that video and say, oh, did you see, his face kind of twisted a little bit there? Is that something you've seen before? And sometimes we can notice things on videos after the fact that we didn't see initially. So take a video, write it down, try to describe what happened at sort of the beginning, middle, and the end. Um, those things are helpful for me to know. Having seen a lot of seizures, or you're a neurologist, they might say, well, this is the progression of things that I would expect to happen, but what you're describing sounds really different. Let's talk through that. So what happened right as it was starting? What happened in the middle? How did the event end? What happened afterwards? Those are all kind of pieces to sort of think about. If you're able to, try and get your child's attention. So note if there's any degree of responsiveness. And this can be, there's a lot of degrees of responsiveness, right? So there's your typical level of responsiveness, which is like, hey, mom, what are you doing? Um, and then there's, levels in between. So there's children where you can tell that they can hear you, but they're trying to speak and they can't answer back. There are children where there's no effort to speak, but there's eye movement towards you as you're speaking to them. That I would still count as responsiveness, although not normal responsiveness, right? They're not acting like their normal self, but are they able to sort of turn their head or look towards you? That is a level of responsiveness that I would want to know. So, are they able to speak? Are they able to report specific symptoms back to you? And sometimes, if it's a pretty brief event, right, and they're recovering pretty well, we'll ask afterwards, did you feel anything? And I'll go through sometimes like the five senses, right? Did you hear anything? Did you see anything? Did you smell anything? Did you taste anything? Did you move in a way that you didn't expect? That's kind of an easy way to think through, like, what types of questions could I ask, a 10-year-old to know, what happened. And then talk to your neurologist. Your neurologist can use the information that's given to help decide what type of seizure is happening, or potentially get an EEG for better diagnosis, right? Because sometimes we just can't tell. Even with a good description and a good video, if it sounds very much like your previous seizures, we'll probably say, yeah, it's probably a seizure. If it sounds very different, we might say, we're not sure. Let's adjust your medicines and see what happens. Let's get an EEG and make sure we know exactly what we're dealing with. So, lots of options in terms of knowing like when it's not super obvious, what are the things that we can do? So, seizure tracking methods, just a quick disclaimer that, I don't have any like vested interest in any of these. So, not an advertisement for any specific device or specific program. But there are lots of different ways to keep track of things. Um, this is a classic, right? Notebook, pencil. Families come in with sort of seizure diaries or seizure notebooks on paper all the time. That works well for you. That's great. Loads of people come in with their smartphones, and have information tracked that way. There are specific seizure tracking apps that are available, on either iPhone or Android. And if you just Google them, you can find several. Seizure tracker is a pretty easy one. Epilepsy tracker. There's one called Epsy. Some of them do require a subscription fee, so just be aware of that. Some of them are free, but some of them are not. And they can do various things. So some of them, it's literally just a type in your types of seizures, and then you click a button on a day, and it says it sort of counts that seizure for you. Others, it's a little bit more, intensive. Some of them will give you a spot for every single seizure to jot down exactly what happened. So you can investigate and figure out which method works the best for you. But I don't write, like, if I don't remember anything, right? If I don't write it down, I don't remember what's going on. So I pretty much always recommend that you jot something down if you need to. Seizure monitoring devices are the next piece. So again, not an advertisement for any specific device, but there are a lot of different options out there. And so a few sort of disclaimers about things. There are lots of devices out there. They all have pros and cons depending on your unique situation. None of them are foolproof. So they may miss seizures, they may give you false positive alerts, and you just have to know that going in to know, is this device going to work for me? None of them right now predict when seizures are likely to occur. We'll say this is an active area of research and people are interested in this and trying to figure out, can I predict based on somebody's seizure pattern, when a seizure is likely to occur? We're not there yet, but people are looking at it. And none of them at this point detect seizures without obvious motor movements. So people are also looking on this, looking to find some answers about, are there wearable devices that are some degree of EEG, right, without having a whole EEG on your head? Are there some wearable devices that could identify seizures even without obvious motor movements? Not there yet, but people are definitely working on it. So we'll see what happens over the next 5 years or 10 years or 15 years. I expect that, the information here will change over time. The devices available for seizure monitoring generally fall into three main categories. So there are wearable, sort of wristwatch type devices, camera-based devices that are typically used for nighttime monitoring, and mattress pad movement monitors. And most available things sort of fall into those three categories. It's really important that families know, like, you don't have to use one of these, right? 50 years ago, we had none of this. I had an attending who trained me when I was in residency, and she had worked in a really resource limited setting for many years. And she said, we have all this cool technology now. Do you know what we used to use, 30 years ago? Families would sort of have their child wear a bracelet with bells on it, because then if they shook in the middle of the night, their parents could hear it. So there are low tech ways to think about monitoring, and there's also our sort of higher tech options that we have now. Um, every situation is unique. So what works for one child or one family may not work for you. Um, and these devices are not covered by insurance, largely speaking. Every once in a while, we find one that will cover at least part of the cost, but largely they are not. And currently, costs range anywhere from about $300 to $500 for these devices. So there are some foundations that can help support the cost of these when needed. And the Chelsea Hutchinson Foundation and Danny Did are both a couple of options for folks that do, look into this and help families cover the cost of devices if they're interested. Because by and large, families are interested in having some sort of monitoring. And again, every situation is unique, but I definitely see a lot of different is for how families do this. Um, Most families worry about nighttime safety, right? Kids may be at school during the day with, teachers or paras or people who are around them. That feels like a lower risk scenario for a lot of families. But nighttime, can feel really scary. I don't know if a seizure is going to happen. I don't know how I'm going to know if it happens. I definitely have families who bed share because that feels safe and comfortable to them. And that's certainly an option. I also have families where that doesn't work for them for whatever reason. Maybe nobody gets any sleep if they bed share. Maybe that's something that culturally they don't want to be a part of, and don't want to sort of have that be their norm. It also becomes more challenging when kids get older and become teenagers. Teenagers tend to want privacy. They tend to want independence. That's a huge sort of push-pull for parents of teenagers to say, my teenager wants independence, but I want to keep them safe. How are we going to do that? And that's normal for any teenager, let alone a teenager with epilepsy who now has some additional safety concerns involved. So I have definitely seen these types of devices be one part of a family's way of dealing with that. So saying, none of us are sleeping well. I want you in your own room. You want to be in your own room. Let's use a baby monitor for sound or a camera-based monitor that can alert me if you're having abnormal movements in the middle of the night. Um, Everything is really customizable to sort of what works for you. And I think the way I approach these is find something that works for you and improves your overall wellness, right? There's a lot of stress about epilepsy. There's a lot of anxiety. There's a lot of worry about nighttime and about seizures. And so find something that helps everyone get a little bit more sleep, that helps everyone dial their stress down a little bit. These devices are not going to do that entirely, but they can be a piece of the puzzle to sort of help families get a little bit more sleep and a little bit less stress in their lives when it comes to nighttime monitoring. When to call your neurologist? So much of it depends on you and your situation. So, broadly speaking, we start with the goal of seizure freedom with medications. We get there in about two-thirds of people with epilepsy. So two-thirds of people are seizure free with medications. And so for us, like your neurologist probably wants to know about every single seizure if your epilepsy is a recent diagnosis, because we always start at that goal of seizure freedom. And so I don't want, your child to have a seizure and you come to clinic 3 months later and you said, oh yeah, they've had 3 or 4 seizures since I last saw you. And I would say, gosh, I would have changed something. I would have adjusted something because my goal is no seizures. The flip side is that there are, right? So there's that 1/3 of children for whom seizure freedom isn't going to happen. And that sucks. There are also times that we're making changes to medicines and we need a little bit of time to see if those changes are going to be effective. And so in those cases, your neurologist may say, like, it's okay, you don't have to call me for every seizure. We're going to try this. We're going to do this for 2 weeks. Call me if that's not working in a couple of weeks and let me know what's going on. So very unique. I would say work with your individual provider, your individual neurologist to know sort of what they're looking for. I think I'm never worried about getting too many calls, right? If you call 3 times a day, that might be a little much, but generally speaking, I'm not worried about getting too much information. I always feel really sad when somebody comes in and they're like, well, we've had 5 seizures since our last visit. I just go, ah, I wish I had known. So work with your own neurologist and your own unique situation to know what's working. Because you guys should, generally speaking, have some agreed upon treatment goals. And if you're not meeting those treatment goals, chat with your neurologist. That is the majority of what I wanted to get through. It's a sort of broad overview of different things, but hopefully useful. I see there's one thing in the chat. Oh, Mark had to leave, but that is awesome. So I am open for any questions. Again, so much of this may or may not sort of be applicable to you and your situation. So if you do have specific questions, I'm very happy to chat about those.
Thank you so much, Dr. Reed. That was really helpful. And yeah, if anyone has any questions, please just unmute yourself and ask the question, or you could use the chat as well. And Kristen just typed something into the chat. Said, "What are some ways to differentiate sleepiness and disorientation versus seizure event?"
Yeah, that's a really tricky one. So are you talking about like, kid wakes up and they're like confused and out of it, and your question is sort of like, gosh, are they post-ictal waking up, or did they just sort of wake up confused? Um, yeah, I would say that can be a really, really tricky one. Um, for many families who have sort of seizure monitors, we look, especially for ones that like record video, those can be helpful in those situations because we can look and see, did anything happen before the seizure, before that arousal, before that wake up happened? Were there any twitches or abnormal movements or things that looked like their typical seizures as they're waking up? The other questions I'll typically ask is, because waking up a little bit confused and disoriented is relatively common. There's actually a disorder, a diagnosis called confusional arousals. And those, right, it's sort of exactly what it sounds like. It's waking up confused, out of it, disoriented. So it's not an uncommon thing. So I'll typically ask, did this happen around an illness? Did this happen around a time that, they were really, went to bed too late, got their meds at a funky time, had allergies, some other thing that would trigger it. If it's, related or temporally to like, hey, yeah, we were out traveling, things were different, they woke up in a new spot, I'm going to be less worried about it versus if it's the same type of thing that happens repeatedly, that's the time that I might say, gosh, if that type of event fits for your epilepsy type, I might get an EEG and see if we can actually record one of those because it can be a really, really tricky thing to tease out. One thing that I'll say about the majority of seizures is that if you have, specific types of seizures, those seizures should look generally the same time to time to time. So if you're having an event that's completely different, I might pause a little bit longer and say, I'm not sure, versus if you notice your child wake up, they're sort of disoriented out of it, and then they're really, kind of groggy and takes a while to get back to normal. And that looks a lot like they look immediately after one of their typical daytime seizures. Then I'm going to say, gosh, those two things match up. And if you have a consistent seizure type, that may be something that's a little bit more worrisome. So context matters. What happened before and after matters. Does it look the same or different as something that you've experienced as a seizure before? And if we can sort of suss it out through that, we'll often try. And then there are times where, with a really difficult to describe event, like a confusion or arousal or things like that, we may have you guys come in and capture it on EEG if we still can't figure it out based on those pieces.
Great. And just a follow-up question, she asked, is there the questions I should ask that could help? If she's able to answer her name, etc., less likely during her seizures, she's unable to make meaningful words or actions.
Yeah. I would say if it's similar to her typical sort of ictal or post-ictal behavior. So if you've asked her that during or immediately after her typical seizures where she is unable to answer her name, and that that's a consistent feature, a relatively consistent feature, then that could be helpful. So some sort of basic orientation questions. Where are you? What's your name? What's my name? And again, if that's similar from a typical seizure to this sort of new nighttime event, then that may be a piece that's helpful. Yeah, absolutely. So asking, and also asking the child how they feel. It depends on how old they are, but if they're able to sort of describe anything about how they feel after their seizures, sometimes you can ask them in the moment too of waking up and say, do you feel the same as that? Do you feel the same as what you feel with your typical seizures? They may or may not be able to tell you, and that's totally okay. But sometimes that can be a piece of trying to figure it out.
Okay. And there's another question. Does a diagnosis determine what kind of symptoms you might have during a seizure? For example, with a focal epilepsy diagnosis, can a child manifest generalized tonic symptoms?
Yeah, so great question. Generally speaking, what happens during a seizure should be dependent on what type of epilepsy you have. The big caveat to that is that, so right, generalized seizures really should never have that like aura, right? So you should never say like, oh my gosh, I have this like weird smell and then I go into my seizure, right? A generalized seizure should really never do that. Focal seizures can be trickier because you often get that sort of lead in and warning, but there are people who don't have that. So there are people with focal epilepsy who really, to my eyes looking out at them, I would say I wouldn't have known from the outside that that was a focal seizure because they just sort of fell down and had those bilateral tonic clonic movements. I would say bilateral just tonic, right? Just that stiffening would be a little bit unusual for a focal seizure, but you can definitely have something that looks like a generalized tonic clonic seizure and actually have it start focally. Part of it depends on how rapidly it spreads. So there's some people where there's this really slow, it takes 30 seconds for that seizure to really spread from its tiny focal start out to affecting the whole brain. And there are people where it's really fast, right? I'm going to have a seizure and then they're into a full, generalized tonic-clonic seizure and they wouldn't have known. So focal seizures can look a lot like generalized seizures. I would say generalized seizures really should never have that sort of focal lead in.
And with focal to bilateral tonic-clonic seizures, sometimes there can be lateralizing features or things that kind of demonstrate that it might be focal to bilateral, even if it's not reported necessarily by the patient, like
Yeah.
version or that sort of thing.
Yeah, absolutely. So that's a really good point. For many people, even if they don't have that aura or that kind of warning that I'm talking about, there are times that you can really tell it's still a focal onset seizure. And so what Russ is sort of mentioning is if you have a bilateral tonic-clonic seizure, but it starts with a head turn to one side, that actually tells me that it probably started focally. Because if it lateralizes or if one arm really stiffens first before the other one, even if you end up with both sides involved, if it starts with one side or a head turn or eyes turn to one direction, that typically tells me that it started focally, even if somebody didn't have that aura that they could describe to you. So yeah, really good point.
Another question in the chat. What are some key indicators for medication change, especially if a patient has been seizure free for 2 years and then starts experiencing seizures?
Oh, I'm so sorry if that happened for you and your family. It's always super disappointing. So I think um, what you're asking is, so number one, many times people ask, well, what happened? We've gone for 2 full years with no seizures. Why did our current dose of medication that seems to be working well, why is that not working anymore? So I think that's part of the question. The answer is sometimes we don't know. There are times that growth matters. right? So if your medication dosing hasn't been updated for weight gain, sometimes I worry that that is why seizures came back, even though we know. And then, yes, you asked, does puberty influence or play a role with seizures in adolescence? And I think the answer is yes. What's fascinating is that it's not consistent individual to individual. So we actually we're working on a small scale sort of retrospective research project, but to say, can we tease out, do seizures change in a consistent way with puberty? And the answer is not consistently, but frequently they do change. So there are some types of epilepsy that remit in adolescence and around puberty. There are some types of epilepsy where seizures just seem to kind of go off the rails around the time of puberty. And we assume that there's some sort of hormonal impact that's happening. And so, if your seizures came back after 2 years, is it you grew and your meds didn't get adjusted, for weight gain? Is it that hormonal changes are really triggering something to come back up? And then the third answer is, we often don't know. Uh, so in the same way that I can't often tell you why did my seizures start now instead of 2 weeks before, 4 months later, I often can't answer that why now question at the very beginning. And similarly, sometimes I struggle to know how to answer that why now question if seizures come back after a prolonged period of seizure freedom. There's probably some environmental things that can do it. So, illnesses, inflammatory reactions, things happening in your body, again, hormones, weight changes, things like that. There aren't medications that should be strongly affected by age, meaning there's not a medicine that I would say, well, this works great for 6-year-olds, but by the time you get to be a 10-year-old, this medicine is just known to not be effective anymore, right? There aren't medicines that have that specific feature, but there are definitely times that either someone's epilepsy or whatever it is that's sort of hormonally going on in their body has changed enough that perhaps the medication that worked when you were younger no longer seems to have that same efficacy. So typically if I'm in that situation with a family where we've had a good, couple of years of seizure freedom and then seizures come back, my first step is if I have room to increase your current medicine, I'm probably going to start with that because you've probably tolerated it well. We think it worked well for a long period of time. And so maybe we just need to adjust our dose. Even if there hasn't been a lot of growth, maybe we just need to try a little bit more. There definitely comes a point where we're either maxed out on our dose or we're having side effects or we've tried 2 or 3 increases and we're not making progress. Those are typically the times that I would say, okay, for whatever reason, even if I can't pinpoint it, this is not working. And I don't tend to belabor one particular medicine option for a really, really long time if I don't think it's going to work. And so there are definitely times that we say, yep, we've tried 2 or 3 different changes. This is no longer working for us. Let's switch to something different.
Okay, great. Another question, do all seizures make the child urinate, or does that just depend on the type of seizure?
Yeah, great question. Very much depends on the type of seizure. So, losing urinary continence or even like fecal continence. So, some children actually stool during seizures, which is also not fun for anyone. But that's very much dependent on the type of seizure. I would say it's most typical with a bilateral or generalized tonic-clonic seizure. So, very often you'll hear people ask about like tongue biting, loss of urine, muscle soreness. Those are all very commonly seen with bilateral tonic-clonic seizures. There are other types where children actually lose urinary continence. So some even like focal aware seizures, there are children who sort of lose their urine with those, but it's less common than with bilateral tonic-clonic. Say the majority of people with like focal aware or, those sort of smaller, more localized focal seizures, most of those children don't, although some still do.
And just kind of as a follow-up to that question, there are certainly instances where seizures can occur but are not witnessed. And those are examples of things that might suggest that a seizure occurred, urination or tongue biting or cheek biting or that sort of thing.
Mhm.
And then seeing your child in having post-ictal symptoms can be another, like confusion or disorientation or sleepiness, without having witnessed a seizure. How do you, if you, like, let's say your child's in a different room and then you go in or to check on them and you notice that they're kind of out of it or they're sleeping, or how do you determine if maybe you missed a seizure and then they're in the post-ictal state, and how do you not over interpret those types of symptoms?
Yeah, I mean, I think those are really tricky things. Certainly, bedwetting is often useful if you know that your child typically has, seizures where they do wet wet themselves or lose urinary continence. That can be a really helpful sign. The snag is that most healthy 4, 5, and 6-year-olds do wet the bed at night sometimes. And so typically we're trying to piece together as many pieces of information as we can. So, you know, is it just bedwetting, but they woke up and they seem totally normal and totally fine? Or did they, wet the bed and gosh, their tongue seems a little sore, they seem a little out of it, they're pretty sleepy today, they're telling me they're not feeling well. I might be a little bit more worried about that than a kid who just goes, "Ooh, I went to bed. I didn't want to tell you I was embarrassed about it." And we move on. So it's gathering as many pieces of information as we can and matching those things up with what do I typically see when my child has a seizure to see if we can, make the best decision possible in terms of should we change something or not. There are times that we'll say, this only happened once. Let's wait and see if it happens again. Because if it's really a seizure, it's probably going to repeat itself. There are times where it's happened a few different times and we're not 100% sure. And we'll say, well, you're at a pretty low dose of your medicine for size. Let's go ahead and increase your dose a little bit and watch to see if these get better. If they get better, odds are pretty good it was a seizure. And then there are times where we say, too many crossed pieces of information, not enough there. Let's get an EEG and figure it out if it's a repeated event.
Great. We have about 5 minutes left. Any other questions? Oh, your audio is not quite
Nice.
working.
Um,
Can you try again, or maybe type in the chat?
Yeah, I'm so sorry. I couldn't understand
Yeah,
anything.
it was all choppy. Um,
can you hear me?
yes,
No.
but you're muted now. We could hear you if you unmute. We can hear you. Yep. Can you ask your question? Let's see if we can hear you.
I think my
Yeah,
connection is not
yeah, the
good.
connection's not good
Can
right
you hear
now.
me?
Yes, briefly. Yeah.
Very briefly.
I don't know if you're able to type in the chat, that would be great. And we can check there. In the meantime, as you're trying that, if you're able to, we did get another question saying what are good devices for monitoring focal seizures besides cameras? Oh,
Yeah,
that's
I
a tough
think
one. Yeah.
that's a tricky one. There really aren't good devices. And there's kind of two ways to think about that. One is, obviously we want to know the devices are really designed for the seizures that are more likely to be, scary or potentially even life-threatening. So the devices are really geared to capture seizures with motor movements, like those big bilateral tonic-clonic, generalized tonic-clonic seizures, because those are the ones that are associated with higher risk, particularly if they're happening happening at nighttime. So those really are the ones that these devices are geared to catch. For more focal seizures, as of right now, we don't have a great device that can capture those. Even some of the kind of fancier ones like the epi monitor, it Empatica will say, like the company that makes it, they're like, well, it's not just measuring movement, it's also measuring like skin temperature and skin electrical conductance via some proprietary method. And that's great, but without some additional movement, it's very unlikely to be able to pick that up. So cameras are a good option, and then reporting of what you see. There are patients that I see for whom we know that seizures can be really subtle. And so we do periodic routine, screening EEGs, where sometimes we can even do it at home, where you do it, sort of overnight EEG at home. And we'll just screen you every few months and say, we think things are going well. Let's check in periodically and make sure we're not missing something really subtle, because there are times that we just don't have good enough devices to figure it out.
Okay, and we have in the chat one more question. And sometimes we observe unusual tiredness in the morning. We suspect a mild seizure might have happened during the night. Generally, we don't report those to the neurologist. Would that be something good to report alongside regular seizures?
Yeah, I would say yes, particularly if you're in that zone where you're only on, one medicine or a couple of medicines at lower doses and we have room to adjust. I think it's worth chatting about that to say, how suspicious are we that seizures have contributed to this? And if it's a repetitive event that we don't find another explanation for, then I think it's worth at least trying to adjust medications to see if we can get that to completely go away as well, especially if we're in that zone of like, we're still really trying to achieve seizure freedom. And so I think if it's fits more of those criteria of, I don't have another cause, this looks like what my kid looks like after they have a seizure. Maybe there's some other pieces about it that make you more suspicious. I would say, yeah, reach out. Tell your neurologist why you're worried and what you're seeing. And you guys can decide together if it's worth making a change or not. So yeah, great question.
Okay, just one more question. Lastly, how about increased heart rate? His heart rate increases a lot, uh, or the running or jumping. Are there recommended apps that will alert the parent from the child's device?
Yeah, heart rate's a tricky one. You might know that we capture EKG, or a single lead sort of heart rate monitor, with all of our EEG. And so I can tell you that just normal waking up out of sleep, if you hear a sound or something happens, your heart rate jumps up pretty quickly. So it's not a super specific thing. You mentioned sort of running or jumping. Yeah, kids around at school, I generally don't recommend that you have a heart rate monitor that's going to alert you when you're not there, because you're going to get alerted when they start running out to recess. Um, Heart rate can be a piece of the picture, but I think it's typically not as useful as an individual marker. I think it can be useful as a piece of the whole, but there's so many other things that can cause your heart rate to go up, even just stress, right? If I'm stressed about giving a presentation today, my heart rate might be abnormal, an hour before, and you wouldn't notice. So I think it's a piece of the puzzle. And certainly there are, right, Apple Watches, Samsung watches, those will identify an increase in heart rate. But I think as an isolated marker, there's too many other variables that I wouldn't generally think it's helpful sort of by itself.
Okay, well, thank you so much, everyone, for joining us today. And thank you, Dr. Reed, for a really thorough and enlightening presentation. So this will be added to our YouTube channel, the recording. So if anyone wants to review it, you can, and share it with others as well. But again, thank you, everyone, for participating.